afternoon, my friends. Happy Wednesday. The doctor is in the house, and welcome back to another episode of To Your Health with Dr. G. My name is Dr. Mark Gomez, a board-certified internal medicine physician practicing out of Edward Hospital in Naperville and Bolingbrook. Hey, everybody. I'm so excited to continue this theme today of hashtag cancer sucks. And I want you guys to repeat that because it's true. But again, we want to create more awareness. So when we started this last segment last week, breaking down brain tumors, the goal of this whole series is to continue to promote more education, awareness, and then hopefully engagement amongst our families, our loved ones, our friends, to go see their doctor, to make sure that they're screened appropriately, but to really at the end of the day to make sure they make an investment in their health and their well-being. All my clinicians that I've had on the show so far, we all care about your health and your well-being. We want you to have success in your health, because as you have success in your health, you're more likely to have opportunities for future success in your life. And remember, your health journey is just part of your broader life journey, so continue to keep that perspective. I'm so excited today. We're doing this hashtag Cancer Sucks series. We're on part 2 today. We're going to be breaking down ovarian cancer. For those of you that missed last week's show, don't forget to go to my website, www.drmarkgomez.com, and check out our breakdown on brain tumors. Next week, we're going to come back and conclude this series about talking about pancreatic cancer. But today, our focus is on ovarian cancer. My experts that I have today are fierce. They're at the top of their games. You know, I always only have fierce guests on this show. But at the end of the day, again, our experts want to be there for you. Again, I want you guys to not take this conversation lightly. I want you guys to really think about it, but also think about how you can apply. Think about the loved ones in your life, those that have been touched by this condition or cancer in general. Again, that's what we call this series, hashtag Cancer Sucks. And the most important thing is to, whatever we talk about today, share it. You know, the best thing about engagement is, like with social media and everything, we have so much opportunity to pass on a broader message, a message of engagement and opportunity. But the best thing you can do today is not let this conversation die. We need to continue to keep this conversation going and make it more comfortable. We have to be more comfortable talking about the realities of cancer on a day-to-day basis. So the best thing you can do is share this episode with your friends, colleagues, loved ones, anyone that you think is touched by cancer or has been touched by cancer. We're going to share this message and engagement. The old saying, it takes a village. It certainly does. So I'm excited to have you guys here. We're live in studio at Intellectual Radio. We're also live on Facebook. And again, check me out on my website, www.drmarkgomez.com. We're going to meet my guests in a few moments, but you know what I like to do every week? I like to hit you with a quick disclaimer. The content of To Your Health with Dr. G is for informational and entertainment purposes only, and that the content is not intended to be a substitute for professional medical advice, diagnosis, and/or treatment. Further details can be found at www.toyourhealthwithdrg.com/disclaimer. So here we are today talking about ovarian cancer and how the show's going to work today. Those of you that have been following us, you guys know the format, but those of you that are new to the program, what I do is we basically interview some of our expert clinicians and what they do, but we're going to talk about it. We're going to keep it very simple. We're not going to use a lot of high-level medical words on things, but we want to make it relatable, and also, again, so that if you have any questions, you can further not only watch this episode, but also talk with your clinicians, talk with your primary care doctor, talk with your OBGYN specialist, talk with anybody that is passionate about these topics. Again, we're here to serve you as clinicians to make sure that as a community we do great with our health. So what I want to do today is I want to introduce my guests. First of all, joining me in studio, I want to introduce a great friend of mine. I've known her for a long time. We were just talking about it off air, like, wow, I've known each other for a long time, but just a great friend and colleague of mine. She's seen a ton of my patients over the years, and I'm just so glad that you're on the show today, just taking time out of your schedule and helping me and my wife Tiffany really promote a broader mission of serving and making sure that people have equity when it comes to their health and their well-being. So I want to introduce my first guest, joining me live in studio, Kimberly Rohan. I have to read her credentials because her credentials are deep. Kimberly Rohan is a board-certified advanced nurse practitioner. She's with Edward Hematology Oncology Group. She's with Edward Elmer's Health. Check her out at www.eehealth.org. Kim, welcome to the show.
Thanks. I'm glad to be here.
Hey, it's so glad to have you too. Hey, let's do this. Let's start this way. Why don't you tell us about where you did your training, and really what is like the day-to-day involved for you, and then what is this theme of ovarian cancer? How does it pertain to you on a daily basis, or what does it mean to you?
Sure. So I did my undergraduate at Rush. I got my bachelor's degree from Rush. Worked about a year and then went back and got my master's. There weren't nurse practitioners when I went back for my master's, so I came out as a clinical nurse specialist. And I worked in various roles at Edward, but with the Cancer Center for the last 24 years, Dr. Hantel and the team at Edward. And then I decided about 10 years ago to go back and get my postmaster's NP from St. Francis. So I've been with the Cancer Center caring for cancer patients for 35 years, or almost 35 years. So I've seen great strides in how we're managing patients, but I feel my job has always been to help patients on their journey, whatever that journey may be. And especially with ovarian cancer patients, it's a challenging cancer. Affects women in very emotional ways, also some very physical things that can occur with that, and their sexuality. So a lot of what I do with those patients is providing emotional support and helping them manage the side effects or managing the sequelae of whatever needs to be done. So I'm really happy to be here with you today to talk about this.
Well, thank you, Kim. Thank you very much. It's going to be great talking about this more. I want to introduce my next guest. He's joining us live on the phone. I've known them over the last year or so when we worked together at Edward Hospital. So I know I had to reach out to him when I came with this idea for doing this hashtag Cancer Sucks series. I knew he was a right fit to really spread a message of engagement and opportunity, and certainly what he sees from a clinical perspective. So joining me on the phone, I want to introduce my friend and colleague, Dr. Basil Imam. He's a board-certified obstetrician and gynecologist with Edward Medical Group. He's part of Edward Elmer's Health. Check him out, www.eehealth.org. Dr. Imam, welcome to the show.
Hey, Mark, thank you for having me.
Hey, you bet. Thanks, my friend, for taking time out of your schedule and helping us support this mission. Why don't you tell us a little bit about yourself? Where did you do your medical school? Where did you do your residency training? And really, what does this theme of ovarian cancer really mean to you today?
Absolutely. I went to medical school at the University of Arizona in Phoenix, and I actually finished my residency training in Phoenix as well, in St. Joseph's Hospital and the county hospital as well, and I ended up doing an extra year of pediatric and adolescent gynecology as well for my fellowship, and then decided to move to this side of the continent and joined Edward about a year ago, and it's been wonderful so far. Obviously, as you know, if you can tell from my training in women's health in general, from young age to old age is kind of an area of interest of mine, of course, and I take it with pride as well. I love educating the patients, and I love kind of walking them through whatever medical issues they are having when they end up coming to see me. Ovarian cancer is obviously one of those things that hit women pretty hard, just being basically the second most common type of gynecologic cancer. So it's definitely one of the subjects that I have interest in.
Excellent. Thank you, Dr. Imam. And not only to piggyback on what Dr. Imam just said, certainly ovarian cancer is the second most common gynecologic cancer behind uterine cancer, but it actually is the most common, the leading cause of gynecologic cancer-related deaths. And so this is why we're trying to have this kind of conversation. So I want to kind of set the tone like this. Usually each week on the show, hey, you guys just met my awesome panel. They are awesome. So each week on the show, of course, we break down some questions. And so when somebody comes into the office, we call it the chief complaint. And that's really when somebody presents to their clinician and is there for a specific reason. So our chief complaint today / question of the hour is this: what causes ovarian cancer to develop? How can the risk be minimized? And what treatment options are available? So I'm going to ask this question to Kim. So Kim, can you give us a little more overview, just general classification about ovarian cancer? A lot of people have heard of it, but what is ovarian cancer? Or we can even take it back a little more broadly. What is cancer in general? How does it start? And then how does it develop? And consider it around ovarian cancer too.
So cancer is really a mutated cell. So a normal cell that how I explain it to patients is our cells in our body are like good teenagers. They follow rules. Cancer cells are like teenagers gone amok. They stop following the rules. They beat to their own drum. And so they found a way to get around our immune system to go ahead and set up shop. And in ovarian cancer, that happens in the ovaries. Like I said, it's teenagers that have kind of gone amok, and now we have to figure out how we're going to deal with them. How are we going to deal with that teenager? How are we going to discipline it? How are we going to get it back into the being a good kid again? So there's obviously, we'll talk about this as we go on, various treatments, various ways that we can do that. But once again, it's just a cell that has decided that it doesn't want to follow rules anymore.
Very well put. And I'm going to start using that analogy. I love that teenager analogy. But again, we're talking about making things very relatable to people so they understand what they're getting to. Because I believe, and I might be wrong, but our lifetime risk for just cancer in general in this population, I believe it's about 38%, at least some of the statistics I've seen from the CDC. Cardiovascular disease is still the #1 killer in this country, but cancer is #2, and it's been #2 for quite some time. But we have to have these kind of conversations talking about the reality that a significant chunk of the population will at some point experience some form of cancer in their lifetime. So let me ask this, Dr. Imam, from a OBGYN perspective, from what you do, why should the public care about this diagnosis? We talk a lot about breast cancer, we talk about lung cancer. I feel like ovarian cancer is not talked about as much, but we need to have these kind of conversations. So why should the public care about this diagnosis?
Well, as you mentioned, Mark, it is, despite being only the second most common gynecologic cancer, but it does account to the most death in women in relationship to cancer. And as well as we've done in all the other gynecologic cancers as far as prevention and early detection, we haven't reached that stage for ovarian cancer. It's one of those diagnoses that takes us aback, and then we always hope that we just have an early detection, but it doesn't always work that way, unfortunately.
Very well put. One of the things that people always say one of the things I talk about as a primary care physician is that, hey, when it comes to cancer in general, and we'll get back to ovarian cancer in a moment, when it comes to cancer in general, I always say, hey, we want people to do things that they can control, and we talk about modifiable kind of risks, things that you control over, putting down the cigarettes, putting down the drinking, that kind of thing, controlling weight, because there's a lot of cancer related to obesity, or at least have a link with that. But there's some things that we can't control. And so I want to ask this question to Kim. Are there other kind of modifiable or non-modifiable risks that are out there in cancer in general, and then maybe we can hone it in on this particular diagnosis?
Well, in general, cancer is a diagnosis of that happens later in life. It's rare. Cancers are much rarer in the younger population. So in general, as we age, our risk for developing any kind of cancer increases. Particularly ovarian cancer tends to be most common in the 6th decade of life, or when women are in their 60s. There's some, and that's questionable whether we call these modifiable risk factors or not. Getting pregnant later in life carries a higher risk for ovarian cancer. Not breastfeeding carries a higher risk. Using hormone replacement therapy carries a higher risk. So are some of those things modifiable? You could argue that not having a child before 25 or 27, 28 or later in life, that may or may not be modifiable based on when you meet the right person. Absolutely. Or how that goes, right? So I think some of these things we know that smoking, is also a risk factor. So once again, I talked about how important getting people to be smoke-free is. So I think there are some modifiable risk factors, but unfortunately, once again, it's obviously a female cancer. It's obviously you can't control your age, right? And so the two biggest risk factors aren't anything that we can really modify.
Well, thank you for breaking that down. I always feel like Mother Nature, and that's just maybe in general as the human experience. We eventually we get aged out, or it's almost like the Mother Nature's aging us out of the population. But yes, as we get older, so many more things come in, and we've talked about that kind of stuff in the show before on various other topics. Just the signs of times when we go there. But this is why we need to have these kind of conversations in general to create more awareness, and hopefully that helps move the needles, or at least buys us more time. Let me ask you this question, Dr. Imam. Have you seen from your perspective, does ovarian cancer, does it discriminate when you think about Yes, Kim just mentioned about a lot of certainly more older women, but are there cases in younger women? Does it also matter? Let me throw you the second question too. Younger women, but also what about women that are from different socioeconomic backgrounds or ethnic backgrounds? Are you seeing any of that kind of differences at all?
Well, in general, as far as ethnic background, it does seem to hit Caucasian women more than any other race. However, in low socioeconomic status, you could imagine that late detection is much more prevalent in low socioeconomic status women, and which obviously complicates the treatment process and the prognosis. And Kim is right. You can't really control the age and the family history, but there are some type of cancers that are seen in young teenagers, like germ cell cancers. Most of them, luckily, are benign. However, about 2% of them can translate to a malignancy.
Okay, well, thank you for giving us some more information. One of the things as I was preparing for the show, and it's interesting, one of the great things for me as a primary care physician and doing the show every week is I get to relearn about a different topic. And I think that's one of the beauties of, well, at least when I got into primary care, because I can know a little about everything versus a lot about one thing. But just to have these kind of conversations, we try to take these conversations seriously as we prepare for these shows, because we want you as the public out there. What we do, it's for you, it's for your education, for your awareness, and then for you to continue to have that conversation with your experts. We always talk about getting the right information from the right sources. What we want to do here is continue to build trust and deliver truth when it comes to your health care. So let me ask this question. I'm going to come back at you real quick, Dr. Imam. We're talking about why right now, why should we care about this? Are there things in general that you're aware of, and I'll throw this question to Kim, same question after your response. Are there any general initiatives that are out there to promote more awareness about ovarian cancer that you're aware of?
Not locally, but there's always, the cancer societies always try to promote more awareness. For me as a practitioner and as a doctor, a gynecologist, I always try to, like I mentioned before, educate my patients. There's always that talk about pap smears, and how well we've done with cervical cancers. And, a common question I get from patients, well, if I don't need a pap smear, why do I need to see you every year? And this is where I go into the, full education mode and explain all the other risks that could be involved, including ovarian cancers, and how a visit to the gynecologist could be one of the best prevention that we have, or at least ways to detect anything unusual early using the gynecological exam. Excellent. So that's kind of the initiative I take, because so far, what is known about the risk factors of ovarian cancer has not really translated into practical ways to prevent cancer.
Thank you very much. Kim, let me follow up with you with that same question. Are you aware of any initiatives right now that are going on to promote this? I contrast this to, like, obviously the marches that we have, a lot of them for breast cancer and other kind of cancers that have much more of a bigger initiative, much more in the common vernacular. But are we seeing any ongoing initiatives about ovarian cancer?
There is a ovarian cancer coalition. It's what you have to realize is the breast has gone so far and above men because, number one, it's women, and it's a lot of women, right? Good and bad with ovarian is the N, or the number of women, isn't as huge. I think the majority of women that are diagnosed with ovarian cancer, they get on this whole thing, well, why aren't we screening women with CA-125s? Why aren't we screening better? And I think Dr. Rob brought up, I think one of the good things maybe is, doing pap smears less frequently, but once again, I think that hurt us a little bit when it came to screening for ovarian cancer, because now women aren't coming in necessarily every year for that pelvic exam. And we know that's the one and only thing that we found right now that potentially positively impacts finding ovarian cancers at an earlier stage. So I think, once again, I think that's where we kind of have that struggle. So I think there's pockets of women that get together and try to have a voice with legislation, or try to have a voice with researchers, but once again, it's not as organized as, let's say, the breast cancer community.
Very well, thank you. Dr. Imam, we're talking about kind of promoting awareness and everything. Now, for our patients that are out there, or sorry, our patients, our listeners, our viewers, whoever you want to call it, those people that are out there that are listening to us right now, are there any kind of classic signs or symptoms that someone may have if she presents with ovarian cancer?
Yeah, well, yes and no. The symptoms are very non-specific, so my advice is always talk to your doctor if you feel anything, out of the norm. Basically, the common ones that are related to ovarian cancer is early satiety. Like, let's say you're getting full a lot quicker than you used to, and abdominal pelvic pain that is lasting more than usual, like I would say 2 to 3 weeks. Bloating sensation, any change really in urination, vaginal bleeding also could, some types of ovarian cancers can present as vaginal bleeding, although not all of them. I always say, if anything's unusual, any of these symptoms that are, albeit not very specific, but last for more than 2 to 3 weeks, then a visit to the doctor is definitely warranted. And then, from then on, we'll take it and we'll perform an exam. If anything is suspicious, there's always imaging modalities that we could use to help us.
Hey, Anna, let me piggyback on that one. Is there anything, Dr. Imam, when it comes to when you're doing your exam, that's something that might tip you off that someone may have this diagnosis?
Yeah, if I find any masses on exam around the neck or around the ovaries, basically, then that usually triggers me to order an ultrasound. Depending on the age and the views on the ultrasound, I can also order some blood tests and tumor markers that Kim alluded to. I mean, they're the best we have so far, but they're definitely not. The combination of both have not been approved yet to be a screening test for women who are at a higher risk of ovarian cancer. But definitely, if a new patient, comes up with a problem, then that's kind of a good first step.
Thank you, Dr. Imam. Let me ask this question to Kim, because I get this quite a bit as a primary care physician. Somebody may have a family history of ovarian cancer, and the patient will come in and say, "Hey, Dr. G, I got a family history." And I always like to ask about family history, but a new family history, for example, and they'll say, "Hey, there's a test that I'm told that I need to get from you called a CA-125," and they always say, "Can you order it for me?" Or they'll say, or I'll get that thing where, "Hey, I got a family history of ovarian cancer. Can you just screen me? Can you just order me a pelvic ultrasound?" How do you kind of approach that kind of thing? I mean, should people be asking for that stuff right from the get-go? I know Dr. Imam basically said I'm putting words in your mouth, but I think I know where you're at, my friend. But really, we shouldn't be doing that kind of stuff because there's no guidelines really to back that up. But how do you have that kind of conversation if somebody comes in and says, I want this, and this, and this because of my cancer risk?
Oh, and we get that all the time, right? So first of all,
Right.
if anybody has a family history, we have genetic counselors that I refer patients to the genetic counselors because there can be certain mutations, BRCA mutations, that may put a patient at higher risk, or a woman at higher risk for breast or ovarian cancer, right? But even with knowing that somebody may have that mutation, there have not, just as Dr. Imam pointed out, we still don't know how the best way to screen those people and how often do we screen them. And this is how I explain it to patients, I could draw a CA-125 on you today and it'd be fine, and 6 months from now you could have an ovarian tumor. How often do we do that? We don't know. And we haven't been able to prove that doing it on an annual basis or every 6 months or whatever changes the outcome for patients. And I know that's really hard and frustrating because I think women sit there and go, well, but men get, their PSAs and the men get their prostate. How come? We haven't proven, and even in prostate, we haven't totally proven that PSA, because the CA-125 can be elevated in benign processes as well. So it's not a specific test. It's not specific to ovarian cancer. It can be elevated in a lot of other conditions. So just trying to educate them. And I think the biggest thing is empowering women to speak up. Oftentimes, you know your body, and if something doesn't feel right, or you feel something's not like it's supposed to be, just keep after the physician until they've worked it up, or you feel like you've gotten some resolution to it. A lot of these symptoms can be associated with IBS. They can be associated with perimenopause or menopausal symptoms. So teasing that out, I think, is often very difficult. And that's where working with your provider, and I think it's important to have a relationship with the provider that you've seen multiple times, that you can have this dialogue with, and that knows your body just as, not as well as yourself, but almost as well as yourself.
Yeah, I think that's perfect, because I always tell people, and I like how you both are really saying this, we as clinicians would rather have people come in and see us and then give them reassurance versus delaying that visit, which can potentially delay their treatment if something truly is found. The old saying, there's no such thing as crying wolf when it comes to your health. And even if people sometimes say, I'm a self-imposed hypochondriac, but we want people to get in. So I like how both of you guys are saying, something's been going on for a few weeks, and at that point, your body, something feels right, something feels off. It's best to be seen. And whether you come in and see your primary care physician like me, or for women out there, if you see your OBGYN physician like Dr. Imam, we want to be there to reassure you. We hope not to have you have to go see Kim from an oncology standpoint, but Kim is there to help you out if we need to go that route. But we always say start with your primary care physician, start with your OBGYN physician, and have that conversation. So let me ask this question to Dr. Imam. So, Dr. Imam, we talked a little bit earlier about risks, about cancer in general, what we should be doing, which obviously I always say, we should be moving more, eating better, stressing less, putting down cigarettes, all that kind of jazz, but have they really seen anything? I was doing some prep for this, and one of the things that I found, and I wanted to kind of ask you both, is an interesting thing that it was here, I'm going to read it so I don't mispronounce this. So if somebody uses birth control, and I read this kind of fact, and this is where we're going to say, does it decrease or increase risk? But say somebody's using birth control. For what I found, at least through the American Board of Internal Medicine, I want to put that disclaimer there, is that use of birth control for 15 years or more decreases risk of ovarian cancer by 50%, with a protective effect lasting 30 years after stopping birth control use. But even shorter results of birth control use, shorter durations, have resulted in some protection. Is that kind of a true statement?
Yeah, that's correct. They've seen some protective or reduction in cancer, ovarian cancer in people who use oral contraceptive pills for 5 to 10 years. I mean, 15 years seems like a lot, but I think our data that I've seen is 10 years as well. So, so obviously it's not a good reason to start oral contraceptive pills just for that reason, but it gives the patient some reassurance who are using it for birth control management to know that maybe she's reducing her risk of ovarian cancer in the future. Other things that I forgot to mention before, but since we're talking about risk reduction, some type of ovarian cancer is believed to start in the cell lining of the fallopian tubes itself. So when a woman comes in and saying, I don't want any more babies, I'm done, my family is complete, and wants surgical treatment, then I've started counseling them, instead of just cutting a piece of their fallopian tube, to remove them entirely. And it's called a prophylactic self-injectomy, so removing the fallopian tubes both in entirety, and that has been shown to reduce the risk of ovarian cancer as well.
Wow, that's awesome, and I'm glad that you're able to have those kind of frank conversations with people. A lot of times when you think about creating more awareness, we have to take action, and say somebody does have risk, you want to take action. So let me ask this question for Kim. Dr. Imam just mentioned one of the surgical treatments, and I'll get back to that in a second. Hold that thought, Dr. Imam. From a non-surgical standpoint, how do you approach somebody in general about treatment options with this diagnosis?
Mm-hmm. So, I think I've been doing this 35 years, and, for 35 years, we've, always had chemotherapy. Obviously, the first step is to get, if patients can have surgery, want to do surgery. If they can't get it all, at least debulking the majority of that. And then that's followed with chemotherapy. We, over the last 10 years or so, we've started to have available to us targeted therapies for certain subtypes of ovarian cancer. And now we're even looking at what's the role of immunotherapy in the treatment of ovarian cancer. So I like the analogy, chemotherapy is the bulldozer, it just kind of plows through it all. And then targeted therapies are more, the sharecrop where you're dealing with just certain plants. And then you have your immunotherapy where you're really taking your own immune system and working toward getting those teenagers, that I spoke about earlier, the teenagers back in line. So there's the exciting thing about oncology is when I started 35 years ago, we maybe have 1 or 2 new treatments every couple months. Now it's almost every week, almost a new indication for a drug every day. So I think we're learning more and more that not all ovarian cancers are the same, and we're starting to understand the biology of what turns your cancer, what's making your teenager be bad versus this person's teenager be bad, and trying to become more precision medicine, personalized medicine, where we're not treating everybody the same, but looking at the biology of their cancer and ensuring that we're attacking this as best we can.
Excellent. Dr. Imam, what are some of the surgical approaches? You mentioned a little bit before, certainly with a prophylactic self-injectomy, taking out the fallopian tubes. But what other options are out there? Say somebody has a diagnosis, and you got to go from there. But how do you kind of advise your patients on what their surgical options are?
Well, yeah, Kim alluded to the fact that the surgical debulking and usually the treatment really is based on staging, imaging, and how it looks on imaging. Really, I usually send them to cancer specialist, and then they have a conversation. But the conversation goes depending on the size of the tumor, how aggressive it looks on imaging. And it's a combination of either surgical followed by chemo or radiation or some of those targeted therapies that Kim has talked about. Or sometimes, they start with chemo and then reduce the size of the tumor a little bit, just enough to make the patient ready for surgery, and then go ahead and do the major debulking process, and then follow it up with some more therapy afterwards as well, until remission.
All right, thank you. So, here we are, we're tuning in here. You guys join us here live on Facebook. We're here at intellectualradio.com on their site, as well as live in the studio. Talking about ovarian cancer, #CancerSucks series. Again, having this great conversation about just what is ovarian cancer, how are we promoting more awareness, how are we promoting engagement, but also at the same time now talking about treatment strategies, options that are out there. And I love how Kim just said a few moments ago that no 2 treatments are the same. You really have to individualize your approach, and it's great that medicine has evolved from a one-size-fits-all to a very individualized, customized approach, because I think from anybody that's dealing with this diagnosis of ovarian cancer or cancer in general, want to know what's their plan for them, because it's such a scary moment and a very emotional moment. And now I'm glad we're able to have you from your end. You have so many more tools on your tool belt, and from Dr. Imam, from a surgical standpoint, again, more better techniques out there to help people continue to overcome this challenging diagnosis. But let me ask you guys this. I'm going to paint this picture. A lot of times to get more awareness about a topic, we have to see something has to happen in the public sphere. One of the most famous people to have had ovarian cancer was former Saturday Night Live star Gilda Radner, but also other famous people have had ovarian cancer, have diagnosed or succumbed to their disease. Coretta Scott King, the wife of Martin Luther King, the late Martin Luther King Jr., Olympic medalist Shannon Miller. But a lot of times it takes that kind of I hate to say it, but like, why does it have to get to the point that a celebrity has to get something first before we may take more action? So I'm gonna ask that question to Dr. Imam first. Why do we have to wait for somebody to do it, to take some of the initiative? I feel like we're still climbing an uphill battle, but we're trying to hopefully get better at it.
Mark, sorry,
Yeah.
you cut off
Sorry,
at the end.
I'll say the question again. Why does it take sometimes, it takes like for a celebrity to come down with a diagnosis before we get a big community engagement on the topic? Why are we seeing that in people in general? It's more just a philosophical question. What do you think we need to do better to not wait for our celebrity crush to get something to take definitive action?
Yeah, I think it just all boils down to like Kim was saying, knowing your body and then trying to just be in contact with your physician, and it's never a quote unquote stupid question to go and ask the physician. And I feel like it's just the society as a whole just kind of turns its attention when someone, like you said, someone famous gets affected by a disease, and it's just the way things have become, especially down to social media. It's good and bad. It's not. I'm not trying to say it's a negative connotation to that. Sometimes it actually works in our favor as physicians and providers. When someone so prominent gets affected this way, then it just brings more attention to the topic. It sometimes brings more funding as well. So I try to take it as a positive thing, and just try to do our part and educate, having an opportunistic approach to educating the women and the patients in general.
Thank you. Kim, your response? Anything on this topic?
Yeah, I think, in general, people still associate cancer with death. They don't, they don't know all the treatments that are available or the importance of early detection or those things. So I think, we've always offered community events on a various cancer topic, and they're not always well attended because I think people, until it affects them personally or through a family member or someone famous, then they start going out and trying to get more information on it. So I think I'm sad for these people, but I do think it does bring awareness, and like Dr. Mom said, it brings funding. Look at the V Foundation that raised all this money for research, or the Gilda House, for support for women with cancer. So I think in some respects it's an awareness, but it also increases funding. Look at, as your topic last week, brain tumor and Biden's son. Yeah. All of a sudden now the vice president had this cancer coalition of prominent oncologists, nurse practitioners, nurses in oncology together to say, okay, how can we battle this? So it's sometimes the match that needs to be lit to get people moving.
And I love how you said the match.
Please
go ahead.
There's definitely a state of denial in general, and it's more prominent in some cultures than others, to the point where they don't even want to say the C word. They call it the C word. So that's a really good point that Kim brought up. That there's definitely some state of denial, and until it hits you or hits someone in your family, you just don't really pay attention to it. And like I said, because 20 years ago, like she was mentioning as well, 20 years ago, it was not one size fits all, but what they don't understand is we've come a long way in treatment for all kinds of cancers.
That's wonderful. And again, this is why we're having this kind of discussion. So I love how we're here today. Let me ask you guys this question. So say, somebody comes into you and sees you both in your offices. I'll ask this question to Kim first. Are there certain questions, say they get this diagnosis or suspicious of this diagnosis of ovarian cancer, are there any questions that you wish patients would ask you, or vice versa, that you want to make sure that they understand as you move forward in this diagnosis? I always want to talk about, we don't want to have missed opportunities, and going through this diagnosis can be very challenging for people. But so here's the question: are there questions that you wish people would ask you, or are there things that you want to say to people moving forward about this diagnosis?
I think the challenging thing is people usually want to know statistics, and we shy away from statistics, right? Because it's a bell curve. Some people are going to do better, some are going to do worse. And sitting here today, we have learned that some subsets of ovarian cancer patients do better than others, right? So I think that's one piece. Number two, I think that for me as the nurse practitioner helping patients, it's really knowing what their supports are, what are their goals, what's important to them, right? Is it continuing to work, so we need to work around that, or is it I have a vacation, a very important vacation, or family reunion, or a birth, or whatever? Is understanding the psychosocial issues for each individual patient, because the treatment, once it's established, the treatment's the treatment, right? It's all the rest of it that I think that makes each patient very individual, and how do we help that patient to the greatest degree, and that's understanding them personally, and like I said, what their goals are, what kind of supports do they have, what is their background, have they ever had anybody with cancer? Because oftentimes a patient will come in and say, well, my friend had chemo and all these things happened, and I'm like, well, not with this treatment. So it's kind of understanding, getting their basic understanding of what they have, what their expectations are of treatment, and kind of setting the stage for them.
Excellent, thank you. Dr. Imam, there's some common questions that you hope that people ask you, or get gaps where you can actually fill in and say, hey, I think it's really important, maybe you didn't bring it up to me as a physician, but I can bring this up to you so you can know more information.
Mm-hmm.
Yeah, I think the family structure is very, very important. Like, what kind of support system does the patient have? It's always nice when they also ask you what kind of resources available to them. Like, who can they talk to? Anybody else with a similar diagnosis? And this is where you can refer them, of course, to those societies. And then this helps me and helps us all individualize as much as possible the treatment plan and the steps forward. And I think it just sets a good precedent to them and gives them an idea of how things might or may not go, despite it being, it's never going to be a set schedule for them or a set approach, but at least that they know what they're getting themselves into initially, at least.
Yeah, absolutely. And I'm a big believer in, certainly in my practice, when we're having some people, to at least start the conversation. If I'm ordering a scan that might suggest this conversation, this diagnosis, certainly I bring them back into the office. And I'm more of that hands-on kind of physician where I want to talk to somebody face-to-face and then outline the next plan, get them over to Kim, for example, for further treatment, for regardless of whatever kind of potential cancer diagnosis they have. But I want to make sure that patients, that everyone has like the right questions to ask. So I'll spend that time to say, hey, it's okay, bring your family member, your friend, let's make sure we clear the air. I want to make sure that, this is a very serious diagnosis for a lot of people. And as Kim was saying earlier, a lot of times we don't talk about it because the C word, or cancer, because we can all comfortably say it, cancer is equated with death. Mm-hmm. And so, but having somebody there to be with you, to accompany you, and then for us as clinicians to show empathy is a great thing to helping people move forward in their hopes and goals of battling this condition.
I think, Mark, the biggest thing is to tell people to stay away from Dr. Google.
Yes, please.
Because they're going to Google, and nobody polices the internet, so there's a lot of stuff out there that may or may not pertain to that patient. So directing them to reputable websites such as the American Cancer Society. And what I love about the American Cancer Society's website is they can pull up on ovarian cancer, and it gives them a list of questions you might want to make sure you ask your doctor. So it kind of gives them that kind of template for what that conversation should look like when they come to see us. So I think the hardest thing is for the patient that comes in and they've Googled, and their brain's all over the place because there's so much information, and what information really pertains to them or not. So the good and bad about instant information today is that nobody polices that and make sure what's out there is good information.
Well, thank you for saying that, because that segues right into my myths versus facts. Thank you, Kim. No, but it's true. But we want people to have the right information, and so we all as people, of course, as humans, we are risk averse. We want to make sure our health is good. We don't want to put ourselves in risky situations. So it's important to have those conversations about the right things out there, the right questions to ask. So Kim just segued me perfectly into myths versus facts. Each week on the show, what we do is we break it down. I'll have a statement, and my guest panelists analysts will say either myth or fact, but this is again about setting the record straight when it comes to your health. And we're talking about ovarian cancer. So there's a lot of myths out there, and we want to set the truth, or tell the truth better yet, and making sure that people have the right information moving forward. So here's the statement. I got first one for Dr. Imam on the phone. Here we go. I'm going to say a statement, and then you're going to say myth or fact. It's going to be kind of rapid fire, and you give us maybe a few sentences on why it's a myth or a fact. Here we go. First statement, Dr. Imam. The majority of women diagnosed with ovarian cancer do have early symptoms prior to diagnosis.
Myth, I believe. Again, it's very non-specific. I mean, yes, it's a fact. It's non-specific, yes. Sorry.
All right, very well.
We do have some non-specific symptoms, correct.
Thank you very much. And again, I know we talked a little bit about earlier that, we want to make sure people, if they're sitting on symptoms for a long time, make sure you get seen, but let's make sure we get seen, though, which is the most important thing. Here we go. Kim, here we go. Statement, myth or fact. Here's a statement. Multiple treatment modalities exist for ovarian cancer depending on type and grade.
True.
All right, please explain.
Well, just as I said earlier, so depending on, there's various types of ovarian cancer. The biology is different. So it may be a pill, it may be IV chemotherapy, it may be, we even do very specialized surgery with intraperitoneal chemotherapy. So there's a lot of options based on what the patient's biology of their tumor is. So that's a true fact.
Thank you. Here we go. Here's a statement, Dr. Imam. I'm going to say this one. I was looking at my list here. I like this one. A pap smear will detect ovarian cancer. Myth or fact?
Myth.
Please explain.
Pap smear is a cervical cancer screening tool. Very rarely, if it has to be like a really advanced stage ovarian cancer to see any of those cells show up on a pap smear, but that's not really what the pap smear is designed for. So a pap smear, we're screening you for cervical cancer or not ovarian cancer.
All right, thank you. We were talking about this one. Here's the one for Kim. We were talking about this a little bit off air, but here we go. I'm going to read it anyways. Here's a statement. Using talcum powder when applied directly to the genital area can cause ovarian cancer. What's your thoughts?
True if you're the lawyer. They have been able to equate some correlation, but once again, how much and how much talc you have to use and how you use the talc, I think, I don't know that we know that, what that means, so just like we don't know how many cigarettes you have to smoke before you could get lung cancer, right? So I don't.
There you go. I think you answered very well.
Yeah.
Here we go. Dr. Imam, here's a statement. Here's a statement. The CA-125 blood test and a transvaginal ultrasound are reliable screening tests for ovarian cancer.
Myth.
Please explain.
Definitely not reliable. As we mentioned, the CA-125 could be elevated in so many different conditions. The most prominent one is endometriosis, and really, especially in younger women, it's very common for it to be elevated. So we use them as ancillary tools, but not reliable screening tools for ovarian cancer.
All right, thank you. Here we go. Here's a statement, Kim. I like this one. Ovarian cysts always turn into ovarian cancer.
Myth.
Please explain.
Well, the cyst is a benign condition. Dr. Brown can probably speak to that a little bit better than I can, but ovarian cysts it's not like all colon cancers start as a polyp. We know that. Not all ovarian cancers start as a cyst.
Thank you very much. Here we go, Dr. Imam. We'll do a couple more of these. Here it is. The human papillomavirus vaccine, the HPV vaccine, will help to reduce the risk of cervical cancer, but not ovarian cancer.
That's a fact.
All right,
yes,
please.
It is designed for, reduction in cervical cancer. Has no benefit to reduce the ovarian cancer.
All right, thank you.
Ovarian cancer is not really related to HPV.
All right, thank you. Let's do this one. We'll do this last one here for Kim. Women who have had a hysterectomy cannot get ovarian cancer.
It's a myth, unless even if women who've actually even had their ovaries out, if they don't take the fallopian tubes, depending on what, can still develop ovarian cancer. I've had patients even that have had total abdominal hysterectomies present with fluid in the abdomen, and it's ovarian.
Yeah.
So it comes
Ovarian
back ovarian cancer. So that is not 100% effective way to prevent ovarian cancer.
Thank you very much. So there you guys have it. We get myths versus facts again. So we got about 5 minutes left, and we've been having this great conversation about, again, this hashtag cancer sucks. Again, we want you to share this show. That's the best thing you can do today. We're talking about ovarian cancer. So we got about 5 minutes left. So at the beginning, we talked about the chief complaint. Again, what are we doing to create awareness? How do we reduce burden? How do we create more opportunity and engagement in people with this diagnosis of ovarian cancer? That's the chief complaint. The assessment and plan, that's when somebody is leaving their clinician's office and they have a diagnosis and, most importantly, a follow-up. So we're going to bring this on home. So I'm going to start with Dr. Imam since you're on the phone. Why don't you give us a couple pointers, a couple tips out there for people. What should people take away from today's conversation about the importance of discussing this theme of ovarian cancer?
They should just know that it's where it stands as far as gynecologic cancers and in women in general, and then what should they be on the lookout for. I really hope this serves as another reason why women should just continue doing their annual exams, continue the conversation with their practitioner, and just really pay attention to anything that's unusual, anything that's different, and not just put it on the back burner, and then to continue with all those preventative measures that we've come up with, and hopefully in a few years' time that we will get to a point where we can detect ovarian cancer a lot earlier, or even try to prevent it as well.
Thank you, Dr. Imam. It's been a pleasure having you on the show. Hold the line, don't hang up yet, but thank you very much. Kim, why don't you give us a few take-home points for people out there to be successful, or just things that they should know about this diagnosis of ovarian cancer? Why are we having this conversation? What should they take away from today's conversation?
I think the biggest thing I will hope that people walk away with is not being afraid. I think a lot of times people still are afraid of cancer. So they ignore symptoms or don't take symptoms seriously because they're afraid of what those symptoms may mean. So I hope that people walk away with this today knowing that there are treatment options, that worst case scenario, this is cancer, that there are people out there that are going to help them. There are treatments out there that can help them, and they can still have good quality of life. So my hope is that this allays some anxiety and fear for women out there regarding ovarian cancer.
Thank you, Kim. It's been a pleasure having you on the show today. And kind of my final thoughts are this. We're talking about this broader topic of hashtag cancer sucks, but again today, ovarian cancer. If you are concerned about it, you have to know your body. If you're concerned about this diagnosis, it never hurts to just talk to your physician. You got to start someplace. You know your body the best. If something's wrong, something's off, don't delay. I'd rather have people come in and see me as a primary care physician, and I can reassure them, or I'm sure Dr. Imam would have people want to see him and he can reassure them. If you have a strong family history of ovarian cancer, continue to ask your physician. The best thing you can do is to continue to invest in yourself. Again, as we know, as you have success with your health, you're going to have opportunities for more success in your life. Do not let this conversation stop today. I encourage you to share this show with people out there that need to hear this message of encouragement and engagement and opportunity. Us as clinicians, we're here for you. We work for you because we want you to have the best that all that life has to offer. So thank you to my guests. It's been a great show. Again, my good friend, Dr. Basil Imam. I want to read his credentials again. Check him out, board certified obstetrician and gynecologist at Edward Medical Group, Edward Elmhurst Health, www.eehealth.org. Check him out. He's excellent. My good friend, Kim Rohan, board certified advanced nurse practitioner, Edward Hematology Oncology Group, Edward Elmhurst Health, www.eehealth.org. And thank you, Kim. It's been a great opportunity talking with you today. And I tell you what, this has been just a great show. Hey, you guys have been listening and watching live on Facebook at intellectualradio.com. This episode is written by Mark D. Gomez, MD, and Tiffany E.R. Gomez. Producer is Tiffany E.R. Gomez. Music is by the wonderful Mr. Havis. Copyright 2019 by MDG Wellness, LLC. All rights reserved. Stay tuned for next week's show. I'm going to be wrapping up my Cancer Sucks series talking about pancreatic cancer. We've got a lot to talk about that. Hey, if you like the show, again, share it. Remember, check me out on my website, www.drmarkgomez.com. Hey, let's get healthy together, y'all. Peace out.